Thank you for joining us for our continued discussion on the road to recovery. How do we meaningfully move forward and provide care to those in need? In part two of our discussion, we'll cover the important considerations as it relates to patient demographics and selection, OR protocols, and other specific operational changes. Joining us to continue the dialogue is Dr. Hanjo Kim, Dr. David Okonkwo, Dr. Nitin Khanna, and Dr. Bobby Kalantar. Gentlemen, thanks again for joining us. Let's start with Dr. Kim. As you start to open up a wider range of patients, can you share your early thinking on what the critical considerations you're using relative to patient demographic, pathology, any exclusions, and other key factors?
Yeah, so as far as the patient demographic and the health status, we definitely are pushing back surgeries for patients who are over the age of 65. And actually more so around 70. Patients who have comorbidities such as history of COPD, anybody with congestive heart failure, and patients with underlying renal disease or liver disorders. These are some of the things that we're using as somewhat exclusions until June or July. And as far as prioritizing cases, just like Bobby was saying, we are prioritizing cases like myelopathy, patients with progressive neurologic deficits or weakness in a lower extremity or upper extremity, patients who have an infection, for example, and those are the cases that we're prioritizing at the moment. In the first phase, we might expand that to patients who have possible concern for opiate dependence. And the reason why is because a lot of these patients are in extreme amount of pain and disability, and for pain control, they can't really go and get injections because that's sort of been curtailed as well. So some of us have been prescribing opiates for the patients to hold them over, and that's a category of patients that we're considering taking to surgery sooner because of a possibility and the risk for our narcotic dependence. So, that's where I see us expanding. As far as my practice, I could tell you that the majority of my deformity patients, like 99% of them, do not want to have surgery right now. They want to wait until July or June to have surgery, or even out to August. The only ones that do want to proceed are sort of the younger patients that are in their 20s or the later adolescent scoliosis patients who I think are fair to say they're relatively low risk for having anything adverse happen from a COVID infection. And, once we're able to schedule them on an elective basis, they'll probably be able to undergo an operation. Now, one of the biggest concerns that I have is that even if we open the doors, the fear in the society is so great that I think it'll inhibit patients from actually coming in to have an operation. I think overall the general sentiment amongst most patients right now is they if they are healthy otherwise and they feel okay, they would prefer not to go near a hospital. That means that if you need medical clearance for these patients, they're not going to be able to get medical clearance because they are scared of even stepping close to any sort of hospital setting if they don't have to. So what I found is that even if I've called some of my patients and said, hey, we could reschedule your surgery to the end of May, we're going to have to schedule your preoperative clearance to the first or second week of May. And because Governor Cuomo has extended the shelter-in-place deadline till May 15th, the majority of the public does not really want to get out of their homes before that point. So I think there's a challenge there that even if you open the doors, things might not be coming back to normal for a little while.
Hanjo, let's stay with you and get your insight on protocols as you transition from providing COVID-19 care at your facility to traditional scheduled and elective spine surgeries. You routinely have an efficient environment at HSS. What changes will you be making to your standard operating procedures?
Yeah, so, some of the changes that I think are, one thing is the practice of terminal sterilization. So until an antibody test or a more efficient COVID viral test is able to be performed and performed more efficiently and quickly, every single scanner, MRI, CAT scanner, where a patient is placed into is terminally sterilized and cleaned between patients. So that's automatic, a significant blow to efficiency, because obviously the scanner is not going to be performing as many images that it can. One other thing is the pressures on quickly developing a stabilized platform for telehealth visits, not just for the surgeon, as Bobby is mentioning, but also for the preoperative visits with the medical doctors who are performing the clearances for these patients. And obviously there's a significant amount of limitation there. You know, things like auscultations of the heart and doing a physical exam are limited somewhat in the telehealth visit. But I think we're going to be forced to try to determine what we can do in telehealth and what's possible with telehealth to try to help maintain some level of productivity as we phase through this time period until we get back to a new normal. And because of the way that different states are peaking and the surge is different in every state, depending on their population and depending on how long their shelter-in-place orders have been in, I think we are all neighboring each other to a certain extent, and we have to be very responsible socially to ensure that the spread is minimized as much as possible. So some of these practices, I think, are going to go well into the summer and possibly even into the early part of fall, depending on how our curves start to look.
Bobby, turning to you, you touched on that topic in our last discussion as well, patient sentiment. How have you thought about addressing the patient concern or perceived patient safety? Are there plans you have around patient outreach from your institution in practice?
Yeah, I think that maybe is the most important question for us moving forward as the curve has flattened and we're deciding to get back into some normalcy again. Understanding that there are probably going to be a couple of peaks and valleys of this virus, for the foreseeable future, which will keep having some effect on what we can do. I think the number one thing that we've discussed is communication and the telemedicine access and really the way we've been able to adopt it. I think the technology has been there, but we've kind of coalesced around it in such a dramatic way so quickly that it has really allowed a good amount of communication with our patients, face to face over video visits. And I think that gives them some amount of comfort, especially some direct communication from their surgeon. A lot of these surgeries in spine really are dependent on a good relationship and rapport between the patient and the surgeon. Some of these surgeries are risky and have very difficult recovery. So I think patients do appreciate when we have that kind of direct communication and they can sort of trust that we are putting in, some safeguards to make sure they're not getting infected. That comes down to a discussion at the hospital level between what are we doing to make sure that they will be safe, and that's the OR disinfection, anesthesia needs to be on board with us. That's something that sometimes we always blow over as surgeons, but really in this case, they're the ones at the highest risk of getting infected if a patient has an asymptomatic coronavirus infection. And so they have to be part of the discussion as far as bringing patients into the operating room. And then I think maybe the hardest part is some coordination between hospital leadership and the regional government. There has to be a coexisting message that will allow patients to feel like it's time. Again, if the hospital is saying one thing and the regional, governor or mayor is saying something different, and the federal government is saying yet something different from them, then it's really going to create a very confusing environment for the patient, and I think they'll default to stay at home and be afraid of surgery. So we need some coordination, and there has been a lot of discussion between MedStar leadership and both the task force in Maryland for Governor Hogan and in D.C. With the mayor. And I think they're trying to put some language together to really have a coordinated response to patients as far as getting back to a safe elective environment. The patients themselves also understand, as Hanjo was stating, that that they are at risk and they have some fear, and that will translate to who will be operating on it. The Washington State has put out a few papers now with some recommendations to return, since they're sort of on the other side of the curve, and they're basing that on ASA classifications of the patient age, as Hanjo mentioned, is a big factor. Complexity of the surgery, what are the odds that it will require an ICU stay? These are all factors that we can really communicate well with the patient for them to understand whether they're at a high risk or low risk, of any kind of either transmission or in fact getting an infection.
David, returning to protocols again, what are you and your administration considering from an operating protocol perspective in order to maintain a safe environment in the OR?
Nitin raised some really great points about safety and the focus needing to be on the safety of patients and also the safety of our healthcare workforce. There are opportunities that I think really need to have a doubling down on in this country, which is that ambulatory surgery centers, in my opinion, should actually grow in their role and focus for spine care specifically, because in many ways an ambulatory surgery center is the safest place in the United States right now to undergo a procedure that can be done in an ambulatory setting. And we're talking about the ACDFs and the micro discs and MIST lifts and all the cases that we know are already occurring in ASCs. When you transition that discussion from the ASC setting to a hospital setting, there are other factors in play. And what we're watching is hospitals rapidly understanding that just from a geographic standpoint, you need to start identifying which parts of your hospital are going to be the COVID units and which parts of the hospital are going to be the decidedly not COVID units. And you need to start partitioning things and isolating things so that the safety of patients who are coming in for scheduled surgery and where you have already gone through a process of confirming that they are asymptomatic and then buffered that and buttressed that with formal objective testing to demonstrate no viral load, that patient population needs to be sequestered from the parts of the hospital that are at risk for caring for patients who are either COVID positive or presumed COVID positive. And so we've done that in our institution. We have designated COVID units. We have also changed the layout of where cases are scheduled inside of our OR suite, just to the points that Nitin was making, where we have COVID designated rooms that have an adjacent empty room so that you can do the air clearance following cases and between cases. And then we have another part of the OR suite where we are not going to do COVID cases, and we can then maintain a higher throughput in that part of the hospital. When you start doing a systems engineering approach to things and thinking through things thoughtfully and mechanistically, we have already reached the conclusion that we're going to be able to accommodate a significant percentage of our pre-COVID era volume within the next month, and that we anticipate by July 1st, again, being back up to full speed, 100% of case volume, if not, in fact, a surge to make up for the fact that during this coronavirus shutdown era, it turns out that people have still developed significant disease problems, not just in spine surgery, but across the spectrum of disease. And we have an obligation to the non-coronavirus infected people of the United States of America to provide great care to them as well.
Nitin, building on that, what are the considerations that you are now incorporating to ensure patients are comfortable coming back to and consuming care? And what patient selection considerations are you incorporating into your practice?
Yeah, so I think those are the right questions. And again, I think a lot of it is going to be local, the decision making. If you have a high COVID density population, our philosophy is basically to treat everyone as if they're COVID positive and create that type of an environment with the utmost safety. I think in areas such as Pittsburgh, perhaps there's a low COVID density, and so the testing is enough. I think there's some questions even out of the news today about some of the false negative rates of some of these tests. And I think when we talk about testing, we have to be a little bit careful because there's a wide variety of tests that are out there. It's still yet unclear to me what the relevance of the antibodies are. It's unclear to me how much of the staff may have already been affected with COVID, how much of the staff would be tested positive for COVID because we haven't done universal healthcare worker testing. So I think there's still a lot of question marks that surround the testing, especially in a high density COVID area. So again, my philosophy would be to sort of crawl before you walk and walk before you run. So take on more straightforward cases, probably try to avoid complex Medicare reconstructions for the short bit until the systems and the processes can be vetted, sort of pressure tested, and then be able to go back and adjust and make them better and make them more seamless and prove that you're able to get these patients, in and out of the hospital in a safe and timely manner. After that, I think once you start doing some of these smaller cases, I think then you can start moving up to cases where the patients maybe need to stay a day in the hospital or 2 days in the hospital. But again, I would probably hold off on doing, major deformity reconstructive surgery. If the patients have waited a month, I would probably hold off on doing something like that, where you're talking about a potential, ICU stay for at least for a few months until some of the other systems again are up in place. I think the tumor cases are the really tricky ones, right? Because everyone talks about these patients with cancer and they're mid chemo or mid radiation therapy. I think those are the ones which would be very, very interesting to follow almost in a prospective manner, so that we're able to provide them with the safest possible surgical pathways. Those are the vulnerable population, and I think extra care needs to be taken when we're talking about that population. But again, those were the ones that really can't wait. I think some of the degenerative, lumbar scoliosis for 5-level, plus surgeries with fusion, 5-level instrumented cases. I think those ones you may want to hold off on for the next, 30 to 60 days.
If I could add to that, 4 months ago, the terms coronavirus, COVID-19, SARS-CoV-2, none of these terms existed in any of our vocabularies. 6 weeks ago, many of us were at the Spine Summit meeting in Vegas. 1 week before the world basically got turned upside down, at least the world in the United States world. We have watched a very rapid transformation of life and medicine in the United States in a very short period of time. All of this is going to be a moving target. Just as we didn't even know what this was 4 months ago, today we are sifting through what is the validity of all of these various tests. Meanwhile, we're learning a whole host of really fascinating facts. The folks out of Stanford did a study in Santa Clara County looking at incidence in asymptomatic people, and they estimated that the community prevalence was somewhere between 2.5% and 4.2% in Santa Clara County. You look at what happened with the Diamond Princess cruise, where it was a contained environment. They put all 3,700 passengers into quarantine for 2 weeks. 3,000 of them were tested, 634 were positive, and slightly more than half of them were asymptomatic. And then when you look at the publication in eClinical Medicine out of China, with the first author, Shakung Lee, Lei, where at the early stages of the outbreak, they looked retrospectively at what happened to patients who were asymptomatic but later found to be COVID-19 positive. And there were some serious complications that occurred. And if you look at the list of cases that were done, it was all the sorts of things that Nitin was just describing. They were ACDFs, but they were also brain tumors, they were C-sections, they were colectomies, they were cholecystectomies. It's the gamut of cases that we see routinely in hospitals day to day. And every one of those patients that was an asymptomatic COVID-19 positive patient subsequently developed significant respiratory complications, and 20% of them died. We're starting to hear some anecdotes out of New York of similar scenarios playing themselves out in New York. So we are in a very, very interesting and delicate time where it's unclear what the implications of all of these decisions are. And all of this stuff has to be done with the full brunt of what we have available to us from a data standpoint, and doing our very best to apply the most effective strategies that we can. And that's why I continue to refer to this as we are entering the testing era. And whether these tests are perfect or imperfect, they are going to be better than nothing. And they're going to be partnered with rational decisions like viewing every single patient as potential COVID positive. And I can't imagine a scenario where our anesthesiologists are going to do intubations with anything other than an N95 respirator mask for any time into the foreseeable future. And likewise, we have to assume for the safety of ourselves and our fellow healthcare workers, but also for the patients, that we have an obligation to assess the COVID status of a patient before doing scheduled surgery, so that we don't expose our patients to an unintended risk profile. All of this is achievable, though, and we can take advantage of this magnificent mobilization of effort and resources that's happening in the United States to craft policies and procedures that are going to allow us to get back to work in a safe and effective manner.
Nitin, as we bring this section to a close, what do you think will have to be done to address the patient's sentiment, and specifically their concerns of being otherwise healthy and going into an environment where they could be exposed to COVID? Bobby touched on this earlier, but what will we have to do as an industry to ensure patients feel comfortable to receive care?
So I think that's a great question, Matt. I think that it's twofold. I think we've talked about some of the systems and some of the process to basically build best practice with a focus on safety, social distancing, decreasing volumes of people in the office and people in the surgery center, cut down to essential staff and those sorts of things. I think the area we have not yet touched on is communication. I think one of the things that you've seen around the US is governors being able to step up and communicate directly to the people and being able to sometimes deliver tough messages and difficult news, but they were able to affect change. I mean, I can look around Chicago and see that the streets are pretty much empty now. And even though some of the younger generation initially had ignored some of the concerns that were brought forward by the government, they've taken heed. And in our area, we're not seeing, a lot of people running around and carrying on. We just don't see it. So I think that second piece is really going to be key and crucial, that the centers, the physicians, the private practices that are able to both effectively implement excellent and safe process, as important as being able to communicate and articulate that process to the patient, is going to be key and crucial to those practices and those institutions that thrive and survive, and those that are really going to continue to struggle through this. Because if you can't explain it to the patient and the patient doesn't, quote unquote, feel safe, you failed. Whether it was safe or whether it wasn't safe, if the patient doesn't perceive it as safe, it's going to be a problem. There was another long piece I read this morning about patients with heart attacks and strokes just avoiding coming into the hospital at all because they just don't want to have any exposure. So I think it's really incumbent on these major health systems, and again the private practices as well. If you're going to run an ASC and do a lot of these things on an outpatient basis, you've got to make sure your process is in place, but you also have to be able to communicate to the patient. These are all of the steps that we're taking to give you the safest possible clinical pathway. Clearly, David's done tremendous work within his institution. The question is, can that work be translated and articulated to the population so that they are comfortable coming back, that they see the pathways, and that David is able to hit those marks that they've set, for July 1st.
Thanks, Nitin. And you raise a great point. Implementing clear operational protocols is just part of the equation. The other part is effectively communicating to our patient populations to provide confidence that they'll be safe and that our staff is safe as well. A great discussion today. Thank you all. In our final episode, we'll discuss the changes that we've made during COVID-19, from site of care to telemedicine, and their potential for lasting impacts coming out of the pandemic.